Hi, folks. Good afternoon. I'm a pretty punctual guy, so let's start on time here at 1:30, especially on a Friday. I do not want to be the one standing between you and a happy hour. So sooner we can finish up, the better. My name is Commissioner Scott James. I'm from Weld County. Katie First is on the line, but she is mobile. She is driving back from Otero County today. I don't want her to miss the beautiful scenery between here and Otero County. And secondly, I do not want her being entangled in any distracted driving incidents. So Katie will be listening in and available for comment if need be. But she asked me to facilitate today's discussion. So thank you for joining us. I know it's an important topic. What I would like to do is just forego any sort of introductions. I think most of us know one another anyway. If you would be so kind when speaking to introduce yourself and your jurisdiction, that would be greatly appreciated. And with that, let's just get underway with agenda item 2 on our agenda, which is a state updates regarding initiatives from House Bill 24-1038, the implementation there. I believe that Debbie Olden Edel, Debbie, she provided a pronunciation on your name, and I blew it anyway. Debbie and Logan Edel from the Colorado Department of Human Services are online. Would either one of you like to take the lead, please, on that discussion?
I am happy to start that off. I don't know if Debbie's going to be able to be present today. I think she had a conflicting appointment. I can provide some brief updates to our progress since we reported out last month. We are tracking the PMO's implementation of the Colorado Training Academy, so the Performance Management Outcomes team through the Provider Services Unit. At this point, they, I think, are about 80% done with their recordings of all of the curriculum and training. They're planning to pilot it internally, so within their team of 5, before they push it out to our QRTP and PRTF staff to pilot, hopefully starting in October. And I know, and I see Barb on here, I know she requested that Jefferson County be able to provide some feedback or at least get a presentation on what some of the curriculum contents are. And I know PMO is willing to do that for any counties or really any providers that aren't piloting it initially as well. So that is underway. I know Dr. Monahan is in the process of getting those position descriptions for her clinical care team panel so that she can hire those 4 folks and kind of develop a plan of attack, I guess, for her clinical care specialists that will be onboarded as a result of 1038. We have our PMO team also out in the field, so they have a pretty clear outline of what they're doing regarding improving treatment plans, so individual child youth plans, discharge, as well as aftercare with our QRTPs and PRTFs. They've met with, I want to say, 50% or so of our QRTPs and have plans throughout September to start meeting with PRTFs to start improving some of those treatment practices. Kind of in line with that, concurrently, over the last 11 months, my unit has been pushing forward rule packets to update the trauma-informed care practices within the provider network or the out-of-home placement continuum. That rule packet is enormous for anybody that's been in recent SubPAC, finance, SubPAC, PAC, et cetera, presentations. It'll be moving to state board in December and has a lot of updated rules in it to include an EDI plan for providers and a lot of the PMO team's efforts regarding improving clinical care. My contracts update for the contracts team, that the RFP for the contracted beds is currently in procurement. So we should be able to, solicit for interest for those 32 QRTP contracted beds relatively soon. So that is positive. And then we did have a midway check-in point the beginning of this week on Tuesday for the universal placement referral form. So we have 9 counties and 2 RAYs who are piloting that. The check-in was really good. I know, Doug, you were there for that. We received a lot of constructive feedback, which I think we're taking into consideration throughout this process. The pilot will end December 1st-ish, and then that group will reconvene to figure out what recommendations do we have and what next steps can we take. But those are the primary updates I have since the last... No, that's not true. I have one more for you. So increasing specialized foster cares are also a part of 1038 for CDHS. Last month, I believe we increased, I'm going to forget the exact numbers. I want to say it was about 10 therapeutic beds. Over the last month, we grew in that capacity. We had a child placement agency who expanded that bed capacity for therapeutic foster care. I do think those are my updates. I will reference my notes and make sure I didn't forget anything, but are there any questions on those updates?
Questions for Logan, please.
Thanks,
Logan,
Logan.
oh, there you are. Hi, Heather, please.
Hi. One, good work getting through that massive rule packet through sub-pack and pack process and all of that. Glad to see that moving forward. Just on your last item, I know I've updated you before, but just for this full group, wanted to let you all know we did have a conversation on specialized foster care in CHSDA's Children and Families group yesterday, where we just did a CHSDA survey to counties and to CPAs. The survey looked and asked questions for counties that haven't been able to create specialized foster care and counties that have been able to, and then for CPAs that have been able to create it. So we do have a survey response summary that I'm trying to get cleaned up and finalized and send out to counties next week. And then some of the county folks and I are going to work on packaging it up for bringing some of those follow-up items here to tackling barriers on specialized foster care, because we just want to make sure all of our efforts are also coordinated with everything going on at the state level. And if there are anything barriers we want to tackle here, let's do it together.
Thanks, Heather. Additional questions or comments, please, for Logan. Jamie, please.
Hi, Logan and everyone. Just wondering all the data and the reporting requirements associated with 1038. Will those all be housed in one area? Will they be readily available for us to look at? Just curious as to how we'll be getting that information.
Yeah, that's a really good question, Jamie, and good to see you again. We are trying to do that in collaboration with the BHA and with HCPF. We've met with Taylor Smith through the BHA and Matt Holtman a handful of times through a plan we're developing to try to figure out how do we report on this consistently to all the parties that need the information. I also think that's part of our quarterly update to you all that will be in written format, is related to anything we're required to report for 1038 efforts legislatively or internally will be provided in that quarterly written report so that you'll see that exact progress. I also report it in a lot of different groups that a handful of you are in. But if there's another cadence or another format that might be best so that you all have some transparency around timeframes around what we're being held to, I think we can look at that too. Oh, I have one more update for you. Sorry, I'm thinking of things as they come. The Colorado Provider Training Academy rules are statutorily mandated to be implemented on the Secretary of State's website by September 15th of next year. So we have already started that internal draft of what those rules should look like and started that promulgation process and submitting the pre-rule and kind of backward planning that. So the tentative plan is to have feedback sessions for those rules in the winter, so like November, December. So just wanted to give you all a heads up on that, that piece of the process is also moving.
Great. Additional comments or questions, please, for Logan on agenda item 2. Okay, seeing none, thank you, Logan. Let's move on to the third agenda item here. I'm sorry. State updates, if applicable, and discussion regarding current initiatives. Kelly or Matt is who Katie has on the hot seat here for me. So if either one of you have comments, that would be appreciated, please.
Yeah, sounds great. Thanks. And I'll take it over. Again, Matt Holtman, he, him, behavioral health organization. So on the kids plan, a lot of stuff is going on right now. One of those is making sure that the plan aligns with a system of care as we move that forward across the state. So we will be not redrafting the plan, but just reorganizing the plan. That will go to all internal departments as part of our monthly leadership meeting and the steering committee meeting. And then so all internal departments will get to review it first, and then we will be sharing it with everybody. So this group can see it, and we'll be sharing it with counties. Might even do one of the Wednesday morning county calls to do a presentation there for folks to see what that looks like, since we've added several state agencies since I last presented it, and several tasks. So that's where we are with the kids plan. We had 14 year one tasks, and we have 10 of those completed. A lot of those are big tasks, like closing the RFP for the BOSSOs, right? So the BOSSO RFP is closed. We are doing scoring. We will have scoring completed by the end of this month. We will have an awardee set and contracting beginning by the end of the year for those BOSSOs. So that's a huge lift. That's a tremendous lift, and making sure that we have those folks doing it. I know there's a lot of people who have been reviewing it specific to children. So there are SMEs looking at all of the BOSSO proposals with the lens of how does this impact the children and youth in Colorado. So just wanted to share that. It's not just a general review. A lot of the other pieces too on that, actually, Logan did a great job on a piece of the kids plan is 1038, right? And that is the work that we're doing collaboratively with CDHS and HICPUF. As far as BHA's piece of the 1038, we will have contracting done and completed by the winter of this year to cover room and board rates for QRTPs for kids not in child welfare custody. So hoping to stop having to push kids towards county child welfare custody to get the room and board rates covered. BHA will begin covering those by the end of this year. And let's see, we are also working to expand independent assessments and those CANS assessments in collaboration with HICPUF. So we have a standardized assessment process across the state. And then we do have rule promulgation. We have stakeholdering coming up very soon. Like very soon, there will be dates, there will be an email. I can't tell you when until it gets approved, but it will be soon. We will be on time. So all of you will take part. No rules are going through to anybody without your input. And as soon as I have that, literally my first email is to like Heather and Jamie and you folks. You'll see it. I promise. I promise. I keep saying that. I know every meeting. I'm not in October yet, so I'm still on time. So we're coming up. And then a lot of the other pieces for high acuity, right? The SMART Act and legislative pieces, we'll be doing that in 2025. So that's a lot of where we are with our state planning. We are also, oh my gosh, looking at data outcomes, making sure that as we move forward with the plan, that we can show measurably outcomes, positive outcomes for this. We want to align that with some of the work that HICPUF is doing because they are measuring some of the same components for Medicaid populations. We want to align that with our work to make sure we're measuring the similar things for all kiddos across the state. So you don't have like an apples and oranges type measurement, that the data is aligned and makes sense. We are also looking at target populations so that, we do identify that there are some target populations across the state where extra work needs to happen. Yes, the plan is for all kids in Colorado, and some kids need more than every other kid. And so what does that look like? So we are kind of moving towards that direction also. I threw a ton of stuff at folks. Also, it's great to see your staff and some of you guys at the Child Welfare Conference in Keystone. It's great to get a day out there, so I appreciate that. Questions, comments, concerns from me on the kids plan?
Jamie, please.
I have one for Matt and one maybe for Kelly, actually. On the data outcomes and the alignment, do you have specific on the BHA Performance Hub, do you have a specific area for children's behavioral health metrics, or is it incorporated with all of the metrics? Like, is there an easy way in the Performance Hub for us to go in and look specifically for children's behavioral health metrics?
So there's a children's and youth data section on Performance Hub. So really what I'm looking at for the plan is I would love to be able to measure success in the different components of the plan, right? Like prevention or screening or those types of things, and show actual a positive impact to the kiddos, So that's I'm looking a little bit more plan related data, but there is a kid and youth section on Performance Hub, and that's very likely where we'll put this once it lands. Yes.
Okay, that's great. Thank you.
And then I'm sorry, Jamie, can I just elaborate a little bit on that piece?
Sure. Yeah.
Before if you had another question. and you'll probably see this before others or as part of it because you're on BHAC. But what we're looking to do is have, when we're aligning the plan around how would we know if we made an impact or making enough impact in, as Matt said, the key components of like prevention and of screenings and of fidelity wrap. And so what we're doing is having, we got input from all the departments from the steering committee, but we're also meeting with the interagency data group. They have a whole different view on what those should be than what everyone else had been thinking because they're data folks. So, and the way their minds think, and they know the data we're collecting across departments. So they're making recommendations. We're going to take that and then get more feedback. So we just wanted to highlight that we're honing in on, if you were to look at the plan and we say we've accomplished these action items, but how do you know we've not, the accountability part is important, is to say doing the things we're held to. But we aren't able easily, we don't think, to actually show progress in these certain key components across the care continuum. And so I just wanted to highlight us trying to do more around being able to gauge success or impact, and then also gaps, and just some of the steps right now that are underway, but have more work to be done. Sorry, Jamie, go ahead then. I think you had one more.
Wait, Jamie, can I ask a follow-up quickly?
Sure.
Okay. On the Performance Hub, which by the way, Katie First from CCI just sent that information out to all the county directors as well, that BHA is going to do a Performance Hub walkthrough very soon. So that'll be great to look at together. I just want to bring some of these pieces together if I can. When I look at the child and youth data part of the Performance Hub currently, so the link you put in the chat, Matt, it's only right now the data that was legislatively required under 1269, correct? But
Correct.
your guys' data teams have been working on other performance metrics for children and youth for a future phase. And do we have any updated timelines on like the phase in of additional children and youth metrics?
That's a great question. Yes. So to your point, yes, we've been collecting and working on oh, you moved in my screen. Sorry. Yes, we've been collecting more. Yes, we want to put it out there, and it really is just time and effort and dollars to get it up on there, right? Like we can't roll everything out and all the time, right? So I don't have an actual timeline on that, but that's a great question, Heather. I haven't had an opportunity to check in with to Jordan and her data team to see when that can roll out. I can ask and see what that schedule would look like, very specific to the youth piece. Yeah, I'll put that on my to-do list. Thank you.
Jamie, please continue.
Thank you. As you know, when we developed Senate Bill 59, we engaged with a lot of national experts and consultants on how other systems of care were created in other states, and we put all of those components into Senate Bill 59 so that we could really try to create that comprehensive system of care. Is the BHA looking at creating a comprehensive system of care with maybe some of those national experts, or looking into what that could potentially look like and bringing that to Colorado? And you don't have to confirm that or not, but if so, we would really love to be a part of that work as well, because we did a lot of work on that for 59 and have a lot of information that we could help you with along the way. So just more of a statement rather than a question.
Kelly?
Yeah, I like that statement though, Jamie. And sorry, my screen just moved. There you are. Two things. One is that we know you're right, and we know that around the national experts and what you've built out. And right now, the focus has been on making sure that the system of care that we're held to as a state from the settlement, that's also informed by national experts and that issue now. So we're aligning with that. And that's where we've been starting, is what is playing out with that and the commitments. And then we're wanting to go a little bit deeper on the prevention and recovery side ends of that continuum. And so that's where we've been starting, Jamie, is with that and what's been guided by their experts. And then there were pieces in your plan, and you all know this early on, or you and Heather do. We did do initial comparisons, what's in the plan. And now that the settlement has happened, we'll see if there were a couple of places like when you dig deeper into the levels of like high fidelity wrap, where it's like respite services. I don't know if that's necessarily like yet in the settlement and how all that looks. But we are going deep on those things and have that in mind on the components you all had put in there. And then, and we'll just keep you apprised as we make sure we're covering everything in the settlement and then being able to see what else there is. Did that answer your question?
Yeah, I think that's really exciting. So thank you.
Yeah.
And we're also happy to roll up our sleeves and help out too. If
Yeah, great, thank
you'd
you.
like us to come to the table. Thanks.
Yeah. And what you're hearing from us, which you all are in lots of meetings, as CDHS person had said earlier too. So some of this is probably super repetitive for some of you. But Matt and I, BHA, have been digging in deep post-session of just organizing the work now that we really know what the settlement is, and then organizing the BHA pieces around that. And we're also doing massive ARPA implementation and rolling out BOSSOs and hit all those July goals. And so lots of big work happening, but organizing the pieces. And that's why Matt had shared too, we're going to create a little bit different way of understanding the plan based on the continuum of care or system of care of how the things are organized too, of what are all the action items in relation to those components on the continuum. And some of you named this early on, that the plan's hard to read in that way. And so just taking this time now that I've been here now a few months, and know more what it is and how it all works, is to just reorganize it in a better way to understand all of that. And Jamie, that could help too, I think, better understand not just all the components and what BHA with system of care HCPF, but also how does the youth plan move forward, the goals around those pieces too. And we want to make that easier to understand and see. And then we want to have the metrics to make it easier to understand our progress or our lack of progress. And so just that's the big work we've been doing post-ledge session to just kind of reorganize it in those ways.
Lots of work. Thank you.
Kelly, do you have anything additional to add to this agenda item?
I want to say congratulations to Heather. I don't know if you all opened with that and I was a minute late, but we were super excited at BHA to have such a good leader in place following Lexi, which really excited about that. I think that is my only addition.
Thank you so much. Kelly, I owe you a response to your lovely and kind voicemail. Also, I think you were the last one before my voicemail got full. So my email is the same. Everything's the same right now, but I just so appreciate all the celebrations and support and really looking forward to everything.
Very good. And congrats, Heather, for sure. Number 4 is state updates, if applicable, and discussion regarding the settlements. Robert, I know you are online, and Katie has your name here on the list. If your name's on the list, then Katie knows you have something to say. Robert, please.
Yeah, I mean, we continue to do the stakeholder presentations. Thank you, Commissioner James and others who attended the Weld County one of our higher attended sessions, so appreciate it. We're doing virtual ones. I just did one at noon today, and I'll be doing one at noon every Friday for the rest of the month. So if you're interested, if you Google IBHS and HCPF, it's the very first line up there. You can click on that link and it will show you how to register for the presentations. Other than that, like, we're just wrapping up our presentation, creating a feedback report of everything we heard, ideas we heard. And then we'll bring everybody back together in a virtual session. And then we'll move forward with putting our plan together for the plaintiffs. We want to have a draft done by the end of the calendar year.
Questions for Robert, please? Okay. Hey, Katie, first, I know that you're driving and I don't want to distract you, but what do you do when you finish a 1 hour meeting at the 25-minute mark? Do you call that a celebration and just take off early on your Friday? Katie, if you can take yourself off mute, do you have anything additional to add?
We have more.
Do you have more? Go, Heather,
We
you go.
We do have counties are prepared to share out. I know the state had requested just to hear anything from counties if there are specific things that are working well with serving high acuity children and youth. So I know, let's see, Catania's here. She's going to share out for El Paso. Boulder, Heather Lucian, I just texted her, so she should be joining in just a minute. And then Weld, Doug and Jamie are here as well. So we at least have those 3 counties, but if other counties want to add on to this as well, I think that would be awesome.
And Heather, you're right. I wasn't done with the meeting. I got to go to the next page. So, yes. So please move on then to the 5th agenda item, which is just that charter review. So Heather or Jamie or anybody who might have some information there, that'd be great.
Who wants to kick us off with the counties? All right, Doug, I'm going to call on you for Weld.
Thank you, Heather. I was looking for my little hand so I could raise it. But sure, I'll be glad to share. You know, the thing for us right now, we actually are in a pretty good situation with some of our high acute, high complex needs kids, which is really good. We've done a lot of hard work in terms of working with the families, trying to be creative and think outside the box and trying to provide different services and whatnot so we can try to mitigate trying to find placement as best we can. I think for us, and I'll just speak for Weld, I know we have worked collaboratively with Dennis and the House Bill 1307 funds to help with a couple of our high acute kids. That has been really helpful. Actually, it was really helpful on one particular one. So that was good to know and good to have as availability. You know, and I think the other thing too, again, so speaking for our setup here with my team, with them being clinical care coordinators, having those licenses around, you know, mental health stuff, being able to identify more appropriate services has been really helpful. And they've also been doing some site visits. And I think that helps with those high acuity kids when we're able to go to the providers and sit down with their staff, talk to the directors, look through the clinical notes, making sure that, you know, clinically they're getting the services and the treatment that they're needing at that time. So that's been extremely helpful. On one of our complex kids, I have one of my workers going down almost weekly to do a site visit, face-to-face visit with the youth. And that has helped, I think, bring a sense of hope for that kid in terms of being able to maintain and sustain where he's at, which has been extremely helpful. And I know other counties have similar kind of roles and staff that do some of those things. So we're not unique, but I think we're a little unique in some of our setup with that. And I think we've just started to build relationships with the QRTPs and PRTF staff and just being able to say, we know this youth is difficult. We know this youth is complex. What can we do to help support you guys? Not just our youth, but what can we do to help support you guys as the providers? Reach out to myself, my team. We're willing to come down, do a site visit. We're willing to do whatever it takes to try to maintain and keep that youth stable as best we can. So those are some things that I've noticed over the past few months that we've been doing that's really seemed to help.
Okay. Anyone else from the counties?
I can go next. This is Catania from El Paso County. Along the lines of what Doug was identifying, I think we have found successes when there is strong and frequent communication and partnership between us and our RAE. For us, it's CCHA. And then within that communication, it's these specific platforms of communication. So we meet frequently with our RAE. Every couple of weeks, we meet with our RAE with standing agenda items and identifying some of the higher needs situations. So, and that includes our placement team workers, as well as our utilization review workers. And also to give a little bit of context, In El Paso County and any rolling 30 days, we have anywhere a rough average of about 100 kids in any space in the continuum that can be identified in high acuity. So that would also include kids that were waiting on an IA for QRTP. That includes kids that we've identified before as stuck in a, whether it's hospital, behavioral health, or medical health hospital, and or detention. So we kind of bucket all of those youth in that space for our utilization review specialists to help kind of move, where we're at, so we're better ensure that balls are not being dropped and what the needs are for those kids. So it's the coordinated or the facilitated meetings between our RAY care coordinators and our staff, and as well as facilitated meetings that happen internally. We call them hub meetings that are also facilitated by our utilization reviewers, our UR folks, to really organize our internal processes. Because what we've recognized and learned is that it's helpful to stay on top of the many moving parts that are necessary for the high acuity needs space, whether or not we have custody of a youth, right? Because we're walking alongside families also where the family is intact, but needs support and help around this. So we found that to be helpful. And you can also understand the reverse of that, right? When we don't have the strong communication between DHS and the RAYs, and where that can kind of start to fall things apart, as well as when we're not being really intentional about our internal kind of tasky meetings. The next piece is the strong communication and partnership and collaboration between us and the hospitals. For us here in El Paso County, it's specifically our Children's Hospital, and it's not solely with Children's Hospital. So when we have solid communication there, what we've also found that works really well is when there is strong communication within the hospital system. So we may have strong communication with certain individuals within hospital, but when hospital has good communication within their structure, then that seems to work very well. And conversely, when there's a breakdown, that doesn't work as well. So we found that to be helpful, as well as really talking through with hospital staff and they having a point of contact that goes beyond a caseworker, to reach out as they need to answer questions to other folks within the hospital system or their management around concerns, needs, issues, regular updates. The other thing that we found that works well, when we all do it well, is when we can be on top of the quick turnaround in time with submitting or receiving things that we need to move kids along the appropriate space in the continuum. So say, for instance, maybe it's an ICPC request to state for placement for a particular treatment facility, as well as maybe it's single case agreements with a facility that we don't currently have an agreement with. So we found that the key places are communication, and no shocker there, right? And it's communication with the RAY as well as the hospital, communication within the hospital, communication within our within DHS, and then how efficiently we can process paperwork, which includes IAs were relevant for QRTP.
Doug, you had a question or a comment, please?
Yeah, I forgot to mention, I think for some of our high acute youth, we're using our high fidelity wraparound program that we have internal. And I think that's been a huge success in terms of being able to do the crisis stabilization plans, the RAP plans, getting that team wrapped around that youth and that family. And it has really, in my opinion, has made it more manageable to work with some of those youth. So I just wanted to put that out there. I had forgot to mention that earlier.
Matt, please.
Yeah, thanks. Question, I guess, for both Doug and Katanya, knowing you're from larger counties. I love the idea of monthly meetings and those types of things, but what about when staff is very limited, right? When we don't have staff to send to have a monthly meeting with the hospital or Ray or those types of things. I love the idea and I want to encourage that. And I'm just trying to think of how that would look in, the 50 pretty small counties across the state.
I think that's a very good question. And I think we got to a space to where we didn't have the choice. Like we had to make it work. And even if that meeting is a 30-minute meeting, it has to happen because regardless, we're going to use the bandwidth of staff time and resources because then what could have been pre-planning, figuring it out, problem solving turns into crisis management of it then gets escalated all over the place around a quote unquote stuck situation. So it became we're going to take the time regardless. And can we and should we take the time more proactively? And absolutely, it becomes, a bandwidth constraint. So say, for instance, then when we know that our internal meetings need to happen in what we call hubs, sometimes those hubs are 15 minutes. It's incredible how highly efficient a meeting can be when you know what the aim and the goal, the vision, the end result, and the high accountability around that meeting is. Also, Doug just triggered another thought for me around what works in regard to then stepping down. What also works is when you have the collaboration and the buy-in and the openness to all parties to allowing transitioning supports into the clinical setting to be able to start that transition, whatever that work needs to look like, right? Whether it's treatment, whether it's assessment, whether it's engagement, so that we can get that youth out of the stuck space and into the next space that they need to be in the continuum. And so when requirements or lack of understanding is present and we're not able to then bring in other resources that we know can help with the discharge, when that's not present, that absolutely can be a barrier. When it is present, we can help things, we can get things moved along. So I would say that can be absolutely a barrier, especially in a hospital setting. Well, not just in a hospital setting, in a detention setting also. So being able to appropriately discharge plan, and the key there, the key words being discharge plan. So having a discharge plan that we all are aware of, keenly clear about, and that then the county can go in and then start to titrate services in or for that child to be out of that facility is helpful.
Heather, please.
Katanya, question about setting up the strong collaboration with Children's Hospital and with your Ray, CCHA. Was that from like a long-standing foundation, or did you do newer things that were really intentional to work on the communication around high acuity cases?
I'd say both. So with Children's, there were, it was a little bit of both, and we had to be extremely intentional. We couldn't just rely on long-standing relationships. Sure, long-standing relationships helped with the kind of that rough initial conversation of what's happening here, like, what are you guys doing? Like that natural kind of conversation that helped that piece, and we couldn't just stop there or take that for granted. We absolutely had to go then and schedule meetings to meet with hospital social workers and charge nurses. And then even then we have to rely that then within the hospital system that they're relaying the information or the updates, the points of contact with the rest of staff that need to know, right? So that has been key. And when that works well, it works well. And I'm not saying that this is 100% perfect, right? Because we're talking about really intense situations that, just are ripe for a rub. But when we understand kind of our processes, our point of contacts, There's clarity of kind of what is driving our pressures at the county and what's driving the pressures at the hospital, even just having those conversations. Little things like that the hospital was just like, where do I go for release of information? Well, who can authorize this or that, and who has custody, especially when the county is walking alongside of a family, does not have custody of that child, and them just understanding that can be incredibly helpful. The same thing with the Ray. And really just saying, hey, when early on, when it was kind of rough, really talking about who's the lead, how do we identify then when care coordinator takes the lead, and or when county takes the lead, and then if we are working together, who takes the lead of what task, and who then becomes the point of contact for family. So I'd say both, and Heather.
Doug, go ahead, please.
Yeah, and I'd just like to echo, I think, we do similar things with what Katanya was just saying. And I think, Matt, what it was is just a lot of persistence. I think one thing as counties, we have to learn to sometimes step back and slow down for a second and kind of go, okay, wait a second, is this really a child protection issue? Is this a mental health issue? And who should be the responsible entity to help meet this family's needs and that youth's complex, high acuity complex needs? And so I think when we've been able to do that, we can then kind of communicate with the Ray, kind of going, and again, I think it's holding them kind of accountable to say, okay, wait a minute, this isn't really our issue. Yes, maybe a little bit, but really this is more mental health, more behavioral health, more Medicaid side. And I think it just takes a lot of time and persistence to continue to communicate with the Rays. Like Katanya said, once you have a contact person, I have 2 of them on speed dial that, I get an email that says this youth's in the hospital getting ready to discharge. And I'm like, okay, wait a minute. Is this youth on the Rays radar? Because we've learned over time, and I'm sure for Barb and Ruby, they can agree that sometimes the Rays weren't even made aware that this member was in the hospital or in the ER getting ready to discharge or whatever. And so once we get them involved, they can do their work on the backside and communicate with the hospital. And we bring everybody together and kind of go, okay, what do we need to do next? Because I think our workers are so attuned to like, oh my God, the hospital's calling me and I got to get this kid out. They're going to discharge them today. And we're like, whoa, wait a minute, just slow down for a second. What's really going on? What can we do? Let's figure this out. Where's the family at? Because we all know we get those reports. Well, the family doesn't want the youth back. Well, that's not what they're saying. They're saying they want their child to be stable, and they're saying they're not stable right now. So that's what we have to start to kind of peel away those layers and figure out what's really going on.
Heather L. from Boulder. I have
Hi,
you on the
everyone.
list here. Hi.
Thanks. I'm here in Molly's stead to talk a little bit about this, and it's good timing because I think a lot of what Doug shared, and then I was here specifically to talk about the same thing as Katanya. So I'm glad to hear there's some universal experiences, a lot of similarities to what Doug mentioned in Weld, our internal high fidelity wraparound team, either being in place when it's really acute to prevent a placement or a seamless transition back into the community has been really helpful. The primary thing that I wanted to talk about was the collaboration with our Ray, who's also CCHA, and it established from the very beginning, I think, of our relationship with them, Heather, to your question. But certainly as things have gotten more challenging, our relationship has gotten closer. And I think they have really kind of responded to the severity and crisis at the same level of urgency and need as we have. And really the collaboration over time, I have seen us really deciding well who's in the lead, who's responsible for which component, and then also moving from collaboration to really working in tandem and kind of deciding what the outcome will be in terms of who's funding the service or who's really the lead after the outcome has been found, essentially. So really focusing on the youth and the family and their needs and working in conjunction with each other to find everything that's possible that's appropriate, and then kind of making some of those decisions. I think CCHA has really helped streamline the EPSDT out of state placement process for us as well. Having to do those multiple components in the past was a lot of different tasks for people to learn and understand, and could create a lot of barriers on referral time and documentation collection. The kind of streamlined nature of using the child and adolescent needs and strengths is also really helpful for us between the IA and CCHA and what we do internally in our CMP. So we're having this common language around what the needs are in the conversation. I also think it's been really helpful at least in my experience with CCHA, that the philosophy around when we use placement, what we use placement for, and what the clinical needs are has been the same. Sometimes when we've worked in collaboration with other systems, the ultimate goal can be different for those partners, and it then becomes really hard to actually work collaboratively. So we're approaching these cases with the same goal in mind and the same philosophy around what services and supports are in the best interest of the youth. And then we can eliminate all of that back and forth on what should we do instead of just really focusing on the task. The Creative Solutions, I think, the meetings have been the primary place where that is happening and really sets the stage for it. And they do an excellent job of bringing in partners and people that the county doesn't necessarily have as strong of relationships with or know when there's a specialty. So that bringing all of the right people together happens really quickly, and that's really efficient and really helpful. And the way that they coordinate, schedule, note take is just wrapped up into a really comprehensive and effective package for us. So I would say that's been the most notable recently, as we have had a number of youth hospital, hub, or office, or detention where we're just focusing together on what we can accomplish. Similar to something that Doug said, our utilization management and placement team are the same people, and they joined the treatment team on all of these cases. So they're following the progress, the barriers, the need for a change in level of care, et cetera, as it's happening, as opposed to responding and being brought in when there's a need for something new. So if they're already established in any of our systems, child welfare, juvenile justice, mental health, we kind of track that right away. And so it's a more it's more of a response to what they're seeing in the moment in the staffings and hearing from the family, instead of having to catch up and then figure out what to do next, has been really effective. I think those are the primary things I can think of that maybe haven't been said yet, but echo everything that's already been said as well.
Heather, thank you. And Melinda, you're on the list as well, please.
Melinda Spalding, I'm with Douglas County. I mean, a lot of what we're doing is really been highlighted by the other counties that have spoke. Our Ray, we do meet monthly at a minimum. When we are having those hard kids or we're feeling stuck, whether it's strategic planning or we call it something else, we are coming together really until a solution is found, when care managers are assigned, and taking it as a collaborative team approach. It's not just their problem, it's not just our problem. We've seen more success with like the hospitals understanding the kids being stuck. I mean, they do get frustrated after a period of time, but they are also getting it, and they don't want to see kids just released that need something higher. And so it has felt like we have a little bit more time or a little bit more grace to slow things down until we can find a reasonable and safe option for a kid, even if it's not a placement. And yeah, we're doing, I mean, just a lot of the same stuff. I had some notes here. I'm just trying to see if I missed anything. One of the things that we've done internally is try to increase the consistency with us on our side, is creating that sort of higher level placement or high acuity kids, like a SharePoint site where our staff's just been able to go in and they know they have absolutely the right documents, most up-to-date releases, and so that's not slowing us down on our end, and that has seemed to help. We have less mistakes, we have less releases being sent back, so things are just happening faster, so we're getting to those meetings and those assessments more quickly. We also do a lot of the same work with Signal on the CYMHTA side, and we have a really good relationship with them as well. And so yeah, I think just that communication, the relationship building, the collaborative approach, a lot of what's already been highlighted has been what's working for Douglas.
Matt, you better reading my notes here from Katie. She says that this was an agenda item at the BHA's request. Do you have any additional questions or comments for the counties?
No, I appreciate everybody sharing that through that in chat, because I think there are some good ideas and things to build off of and things like that. I'm still trying to, I mean, all the counties that shared are well-resourced, right? High functioning, pretty good counties. I mean, right? Like I'm not telling you anything you don't know, right? And it's our counties that are very
Not
small.
every county is a good county,
I meant good as in, of course.
but I know what you're trying to say. I'm sure
Of
others do
course.
too.
Well, it's good
But as a
practice.
commissioner, I can say Weld is the best. So there you
Oh, well, of course. I was getting to that, Commissioner James. For sure. But I think too, for smaller counties, when staff really is 3 people, right, for the entire human service department, when they're understaffed and they only have 3 and they need 6, right? So they have 50% staff. And how does that look? Not to say we can't do some of these things. I'm just trying to problem solve and see how we can do that in some of those more frontier and rural counties who don't place a kid every year, right? And then who run into this problem. So you try to manage time for a monthly meeting, knowing you might not have a kiddo in that facility for 18 months or 12, whatever that could look like for some of those different communities. I'm just thinking about it, but no, this is all really helpful. So I really appreciate that. And I
Jamie,
see all
please.
the hands up. So apparently I
Yeah.
said good, and that was a trigger word, and I didn't mean to.
Jamie, go ahead.
I do know, and I just really respect this group of child welfare professionals from the counties that are on this call. They're amazing, and they just really, really go above and beyond. And I just have the utmost respect for you all. The smaller counties I do sympathize with, and I know it's a struggle when they don't have a lot of experience in this area. The group that you're seeing here have really become experts in this area because they had to be. They're Medicaid experts, they're placement experts, they could be politicians because they're building those relationships, and they're they're making sure that they're doing the best things that need to happen with the needs that we have. And when some of those smaller counties have those challenges, there are times that they do reach out to us, and we'll provide our expertise to them, start calling around on their behalf for placements, even intervene at times with their RAE, if it happens to be our same RAE and we have the relationship. So we really do try and step in and help out when they need it, because, when you have 2 placements a year and everyone you called has rejected your kid, what else do you do? So I think the counties are a pretty tight-knit group, especially in the child welfare area, and really help out whenever they possibly can.
Heather, please.
I was also, same goes on the hospital side, right? With small rural area hospitals and their staff and capacity. I know Megan's on. I've talked so much to Megan Axelrod at CHA about this, and Children's Hospital with Ellen, Jamie, Doug, Jermaine. So many of the county folks have had a ton of conversations with hospitals because we've really wanted to try and plan some type of retreat where the county and the hospital folks could be there together to learn from each other. And if they don't already have certain communication protocols or those best practices of like educational sharing set up, we wanted to flesh all that out. But there are so many logistical challenges, especially with hospital staff and getting everyone in a place together in person. And we just haven't ever really been able to do that. But we've started trying to think a little differently. Like maybe if there are pockets of the state, or like some small hospitals are really struggling, how can we also facilitate on a regional basis, or just pilot that with a couple of different areas that haven't had the time or capacity to really build those relationships and structures yet. So it's still in the air. We just haven't really been able to have movement on that front. It just really feels like something that for a long time we've known as a best practice theme where it does work well. And so if there are any other opportunities to bring it to other places that are struggling, we would love to figure out how to do that, even if it's on a small scale for a little bit.
Tanya, please.
Thank you. I think Matt, I agree with you. You make a good point. And I think the key word here is not monthly or bi-monthly. Like that works for El Paso County because of the volume, right? And that's still a stretch. It's still a resource stretch for all of us, including CCHA. I think the key word here is the intentionality, right? So if I were in a small county, it would be about maybe once a year or twice a year having that conversation of where are we, what does this look like, or can we plan to, if this then that, and that communication strategy, again, knowing those points of contact. So, and that includes within the hospital system, right? So if an administrator is inquiring about something, that administrator knows to go to Sally Sue, who's the charge nurse. And we know that the hospital social worker is talking to the charge nurse and has the most recent update. And this is the person at the county that has the most recent update from the county perspective. So it can be that simplified. Like I don't want to oversimplify it, and it can be that simplified if we just know those key points of contact. And even if I were in small county that I didn't need to, this wasn't a thing for me except for every 2 years, even meeting once a year to say, hi, that's your face, this is my face, are we still all good with this? Are these staff and these contacts still the correct staff and contact? That means everything in the moment of crisis. In the moment of where is this kid going, what's happening with this kid, all the things that we know to be true when we have these moments, just having even that once a year. So again, I just threw out what we do to try and navigate this in El Paso County. And again, nothing's perfect, right? This is what we're doing to navigate it. And we still have glitches in the matrix, so to speak. But I think the key word being intentionality and points of contact.
Megan, please.
Yes, no, and this is Megan Axelrod, so Senior Director of Regulatory Policy and Federal Affairs. And just first off, hugely grateful for all of the work that is happening in the counties and all of the just incredible best practices and opportunity to hear about those today. And I think just to echo what Heather said, we are fully both on board and aware and at the table of just the critical nature of those really trusting relationships. And Catania loved hearing about how that's working in El Paso County, and to the extent that we are keeping an eye out for creative forums for which to build those opportunities. It's really critical and top of our list just to understand, and I think to underscore some of the challenges obviously that both sides are facing, is that the workforce challenges are real in this space, and they're also, these tend to be staff that work incredibly hard jobs and long hours and really mission driven work. And so to the extent that both their time is limited and there are natural kind of turnover functions of that make longer term relationships more difficult, those are some of the things we're thinking through, but I've learned a lot from these best practices today.
Thanks, Megan. Jill, please. You're on mute, Jill. There it is.
I get so excited. Catania and the other experts, can you give this group kind of an idea of what it looks like when you actually have a team working on that high acuity youth and the kind of time that goes into that work when you know you've got to move them and you can't find a place? Like, how much time is that occupying staff?
I can say that that can easily, from the point that the kid hits the hospital, that could easily take up a solid 40 to 50% of the day for a caseworker, more than that for a supervisor and or our UR folks. Because of all of the pieces that we have to do. Well, of course, it also depends on what that kid needs. Is this kid going to go out of state to a facility? Is there ICPC needs that need to happen? Are we pulling together all the documents that need to be pulled together for an IA? So separate from the actual meetings that happen, it is quite extensive to include what are the referrals that need to be made, what are the referrals that were made and they were on a wait list, what do we need to do to pivot or to try and push that youth up the wait list, what do we need to do for the school, and how to mitigate that gap in the school, especially if that youth has been identified as what we've been calling, stuck in a particular space. There's also if that youth needs to be air med traveled from the hospital to a facility outside of our state. There are lots of moving pieces around air med travel, as well as EPSDT. So many of these kids may qualify for EPSDT. So there's navigation with the needs with HCPF on that space that then we partner with CCHA and HCPF with that. So again, it's time consuming in all of these pieces. If the kid qualifies for a waiver, right? So all of these pieces equal gathering information, releases of information, and getting releases to give information to whoever they need to go to. So from a documentation, cumbersome timeline perspective from boots on the ground, it's pretty incredible, which is, and why in El Paso County we've been able to kind of parse out certain tasks of that so that caseworkers can focus on child protection and the safety piece of it, and engaging families while we kind of parse some of that out to UR and placement folks. In addition to that, our placement team then is assertively not only making those placement referrals, but also then following up and calling and striving to make that strengths-based argument, if you will, for why this youth would work for their program or for one of their providers. So I would say from a time management perspective, it is pretty incredible what it takes from there. And I know I'm missing pieces in there, and I see Heather shaking her head, and Barb. So I know that there are a whole lot of other pieces that I'm missing in there from a time suck perspective. But I think it's fair to say very conservatively, 40% on one kid of a work day for one worker.
Heather, please.
Yes, I agree with all of those things. I also think, well, there's such a wide degree of variation, right? If you have a youth who is at your office with nowhere to go, you have staff who are dedicating 100% of their time to supervise, manage, step far outside of their child protection role. And many, many people are doing that and coordinating that in addition to all of the efforts to find placement and appropriate services. So that, I think, for us is, and probably many people, the most extreme version, where we have taken people off of their typical job duties and specialized them to do that for weeks at a time. And then their child protection work goes to somebody else, and it can be really all consuming, the entire placement team, all of those things. When we have a youth who is safe, and I put that in quotes because we're thinking about them in a hospital ready to discharge or in a detention facility where they don't belong and all of the harm that comes with that, then the work becomes a lot more administrative and focused on sending referrals. And there is time to figure out all of the next steps. For the department too, when CCHA is involved and we identified them as the lead, the primary concern is mental health, they are coordinating a vast majority of that work, as opposed to when we have custody and it's really a child welfare case and CCHA is helping us navigate additional services and supports. So there's such a broad range. But what I would say about it is, as much work as it takes more to not do it that way. In the long run, the complications, the things you have to redo, the duplicate work, the things missed, stretch these cases out so much longer, and they become more complex, and the time that the family waits for the right thing just gets longer. It's really hard to move people to focus on something so specifically and intensely in the moment But when we think about how we used to operate in these ways and how disjointed we were, this is ultimately a lot more efficient, and the family is the one who really benefits from the difficulty of figuring it out. But it, you know, to Katania's point, it is a lot. And I think it's the only way we can really practice at this point.
Barb, please.
Thank you. Barb Weinstein with Jefferson County. The only things I want to add is, especially for kiddos who are already involved in the creative solutions processes, that is for some of these really high needs kids. Those are meetings that are happening 2 and 3 times a week. So there is a significant amount of time in the number of people who are attending those every other day until we are able to secure some resolution for a kid. Unfortunately, a lot of that, the majority from my experience, falls to the county in searching for those placements. So in my county, a lot of it is we are meeting, like actually meeting every 30 minutes, especially if the kiddo is either at our office or sitting in an ED somewhere, every 30 minutes to see what have we come up with, where have we heard from, who do we need to reach out to, all the way up to me. Making those phone calls to the people that I have contacts with as well. I have one today. Like my kiddo's been in the ED since last night. So I can tell you from what has happened today is that my time, along with probably 8 others' time, nothing else has happened except securing an appropriate placement for him, which we now have done. So it is 2:30 on Friday afternoon, and that kiddo is on his way from Children's Hospital's ED to his placement. And we were very lucky to be able to find that. So the time, so just today, for 8 people's time all day long to secure that, so that kiddo didn't have to sit in the ED any longer, was still pretty significant.
Doug, please.
Yeah, I agree with everything that's been said. I think, you know, for myself and my team, on our high acuity youth that the state helped us with, it was constant meetings, it was constant calling the state, it was constant calling everybody that we can. And so I think that's where, you know, I've always said before, these might be small numbers of kids overall in the big population of our kids, but they do take up 80-90% of our time just because of the complexities and who we're having to outreach. You know, if you're calling the state or you're calling the Ray, having those main contacts of those people. You know, I have Dennis and I know everybody else has his number on speed dial. We have, you know, Gina Robinson on speed dial when we're having to look for out of state. And it's just, once you start to know who you need to call, it does make the process go a little bit faster. But at the same time, I'm outreaching them, but I'm letting Jamie know, I'm letting Heather know, here's where we're at, here's what we're doing. If we go plan A, we might need to approve this, or if we go plan B, we might need to do this. And so it does eat up a lot of the time. We spent sometimes on a week, my staff and I spent a week on one particular youth trying to get him, you know, from detention out of state back to Colorado. And so again, it just varies on the complexities of what's really going on and what the situation is and where they're at. But I agree, at the minimum, 40-50% of my time and my staff's time.
Additional comments, please. Okay, in my apparent inability to run a meeting, I skipped right over agenda item 5, which is the review charter. Katie wanted me to note that there is a draft that has been available since our initial meeting back in July. But Katie intentionally left the comments that CCI has received on there. Most have been addressed apparently in some shape or form. And if there are any remaining comments or questions on this charter, Heather D, perhaps you could comment more, because apparently you have reviewed it largely, and it's somewhat as it was in its initial inclination. Any comments or wordsmithing that needs to be done on that charter? Heather, any comments on that?
I think we tried to tag anyone that had commented or edited just to make sure any of the changes we made were sufficient to addressing things. I think we're in a really good place on a lot of those. Matt, I saw you jumped back in and had responded to a lot of those. Thank you so much. And yeah, I think, and I would probably say before the next meeting as homework, maybe for everyone just to review it as it is in its updated form. And then we could let Katie know that that's just something we want to have as like a voting item.
Okay, very good. Any additional comments on that charter at all, or that's a good suggestion from Heather to please review, and we'll bring it up in our next meeting. If you are willing to sign on in its current form, if you would kindly let Katie know, send us county logo, that way we can get on board, that'd be wonderful. But I think voting to approve here in the next meeting is a great suggestion. So thanks for that, Heather. Anything else for the good of the order? If not, nobody has ever yelled at me for ending a meeting 20 minutes early, especially on Friday.
Just a big thank you to everybody for sharing. I greatly appreciate it.
I put a note in just the invisible work of government and just how much you all put in to the care for these kids with high acuity, and we all do and care about that, but it's very invisible in the public's eye a lot of the time. So I just wanted to say thank you very much for the work that you're doing that goes unseen. And that I really appreciate. Matt and I put this on the agenda, and we'll probably add more things like this to future ones. We've taken a lot of notes, and I just wanted to say thank you.
Outstanding. Let me echo that from my end, that I appreciate our diligent staff's work. They do amazing work. Okay, there's nothing else good for the order. Y'all, thank you for your time today. Have a fabulous weekend, and we'll talk next time, if not sooner. Take care.